Right? Many of them, they are in the police, some are in the army, some of them they are one of the elite those runners group. Swastika, afternoon might not be convenient to everyone. For me, I can adjust. I told you that mornings they are fixed for fitness, right? So there cannot be any change in that. Otherwise, baki rest is all flexible. So send a mail to me, right? As the schedules are finalized. So all you need to do is about what I said: weekends and the weekdays, and then we'll come up to some common timing, free time frame, which should be convenient to everyone. And yes, it will no problems when if you inform me after the 12th, no problem. Because in any case, it will take about a week to adjust. So as you know that yes, these are the timings which are not clashing, immediately let me know. So I'll keep on making that window, right? I'll keep on adjusting, and then accordingly we'll finalize. All right. So let's start with our today's session where we left off. Right? So last time we talked about tetralogy of Fallot. We'll be going through it at a very high pace so that it is like a quick revision. So congenital heart disease, part 2, part 1, part 2, right? Part 1 was acyanotic, atrial septal defect, ventricular septal defect, patent ductus arteriosus, and the coarctation of aorta. This is where we are. Cyanotic. Cyanotic means baby will turn blue. Baby will turn blue because it is from right side to left side. The blood is going right side, which is the deoxygenated blood, or it has got the carbon dioxide. And it is this which turns blue. When it is oxygenated, it is red, right? Pink. So over here, there will be several combinations. So here, when we talk about right to left shunt, we have got the conditions like tetralogy of Fallot, transposition of great vessels, persistent truncus arteriosus, hypoplastic left heart syndrome, and the total anomalous pulmonary venous return. So these will be the main topics. Vascular malformation, yes, we'll be talking about that. Is on one side there is vein, on the other side there is artery, and in between there will be the capillaries, and then there are some vascular malformations where the vessels, they are at stake. Something goes wrong to the vessels individually. So they are in the form of vascular tumors and atrial venous malformation. We'll see that. Right? Here is tetralogy of Fallot given by Dr. Louis Arthur Fallot. 4 things, right, which we saw into the form of this schematic diagram. And the first one is pulmonary valve stenosis. So this was our first one, pulmonary valve stenosis. Right? Second one, because of the valve stenosis, there will be right ventricular hypertrophy. So this was the first. Second. Third one was this area, that is the ventricular septal defect. And the fourth one is the overriding of aorta, the most important one. This is variable. Overriding of aorta means, very quickly we'll say that as such, left ventricle, from left ventricle, the exit is aorta. But over here, even the right ventricle will also be contributing into the exit of aorta. Right? So that aorta will be getting the mixed blood. In case when it is like pentalogy of Fallot, we will also be adding the 5th component, and that is the atrial septal defect. Most common, 50 to 70% of congenital heart disease. This is the reason we are studying it. Right? And out of all the congenital disease, that is about the brain, about the heart, about the lungs, about the skin, bones, 10%, which is like a huge number, 10% of all congenital defects, they are comprising of tetralogy of Fallot. And this is seen in chromosome 22 deletions, which is called as the DiGeorge syndrome. And this is the 22q11.2. That is the number which you need to remember. Yes, you have to remember. Right? And this is where 22 is the chromosome number. This P and Q, long arm and short arm. So when we say Q, that is the long arm. On long arm, there is one region, that is the region number 1, and there is a band. Region is divided into number of bands. So that is the band number 1. And these bands, they are again subdivided into vertical sub-bands. So that's like a complete whole address. Some portion of it gets deleted. When it is deleted, 1.5 to 3 million base pairs, when they are deleted, then it is called the DiGeorge syndrome. Now, because these so many million base pairs, when they are deleted, it will be affecting formation of thymus. It will be affecting functioning of parathyroid. So there'll be even other symptoms also. So it is not like that in George, we just get tetralogy of Fallot. But when you get tetralogy of Fallot, it should be coming into your mind, yes, let me check the thymus, right? Let me check even the parathyroids, so that you'll be getting a complete picture. So this is, keep in mind, when we'll be discussing all these things, they will be coming into the endocrine system, right? So endocrine system, some of the systems, they are not complicated. Say for example, endocrine system and the neural system, neurology, they are not complicated. Once you know the whole circuit, the way we teach in electronics, right? When first we teach the whole circuit, once you know the circuit, then the moment you say that in this particular sound system, right, volume, we are unable to increase the volume. So you know that, right? That pre-amplifier, it gives the fixed volume, and then there is an amplifier. In between, there is a volume control. So there must be some problem with the amplification system, and the pre-amplifier system is okay because volume is fixed. So that's how logically you will be able to solve all these problems, even in medical. Right? So that's what we'll be discussing. So when we'll be studying endocrine, at that point I'll take it for granted that you have understood tetralogy of Fallot properly. Correct. When the deletion is less than 5, they are called as the micro deletions. So that means is there anything like macro deletions? Yes, there are. Right? So this is what we'll be discussing in genetics. Okay, so X-ray, when we take, this is a boot-shaped heart, 1, 2, 3, these are the 3 points, and this is also called as a core and sabot, right? In French, this is what is called as a clog-shaped heart, right? A drop-shaped heart. So this is the upper part of the boot. This is because of the pulmonary trunk. This is because of the pulmonary trunk, right? Because pulmonary trunk, that is there, right? It will be taking that shape. The toe of the boot, that is upward pointing cardiac apex, because the right ventricle hypertrophy has literally pushed the apex, which was to lie here. Instead, it is pushed up, right? So thus the heart comes off. The heart looks like that boot-shaped heart, like the boot-shaped heart. This we saw into the form of angiogram. In angiogram, we just saw this, that there is a ventricular septal defect, that is one, and there is overriding of aorta, so that right ventricle, left ventricle, they both are opening into the ascending aorta. Same thing, what we see into the form of CT scan. So this is the right ventricle, this is the left ventricle, and that's the VSD, current communicating, and this is the overriding. This was just because we have discussed ECG in so much of detail. So the moment it comes like right ventricular hypertrophy, immediately right ventricle hypertrophy, so that means there is more right muscle mass, right? Right ventricle has got more muscles. More muscles means more current. More current means there would be the axis which was in this direction, that would be shifted, right? That would be shifted, and that is what is called as the right axis deviation. Yes, in one of the email I received that please don't write shortcuts. Well, RAD, LAD, etc. Right? We discussed this thing during ECG. Right? So that's why in reference to that. Otherwise, I don't mind. I'll keep it right. So how to decide? We just go for lead 1 and lead AVF. Lead 1 is negative deflection. So this, for those who are not present in ECG section, for them, right? In lead 1, it would be something like this. So just watch whether it on the plus side the deviation is more, on the minus side. Clearly says that this is on the minus side, it is more. So this will be taken as minus. When on lead AVF, when it would be like this, so then on plus side it is more. Right? So there are lead 1, lead 2, lead 3, AVR, AVL, AVF, and V1, V2, V3, V4, V5, V6 all the way. Right? So thus there are total 12 leads. So in lead 1 and AVF, we see this minus and the plus 1, and then we'll see AVR and lead 2 to see the degree of deflection. But this was just for the reference, right? But as such, you just see 1 and AVF and you know that this is right axis deviation. Then straight away jump to P wave. P wave, biphasic P wave, because there is right atrial enlargement. correct? This is for the confirmation, because right axis deviation can be because of other reasons also. Which can be other reason? Well, electrical system, it is like a tug of war, right? A rope which is pulled on both the sides, right? So either this side is stronger, so then they can pull, or the opposite side is weak. So that means when there is myocardial infarction in left ventricle, right? Myocardial infarction in left ventricle. So when the left ventricle is affected, what would happen? Left ventricle's muscle have died. When the left ventricle muscles have died, so that means no current is passing. So even the normal right ventricle will pull the rope, so the axis would be deviated, correct? So that is important. So the moment we see right axis deviation, immediately you will see two things. One, is there any ST elevation? Correct. I taught you ST elevation. And you will also see right ventricular hypertrophy. So lead V1 to V5, V6. You will see, is there tall R wave? Because big R waves will be there, right, on the V1 side, that is near the right ventricle. And V5, V6, they are very far. So there would be sinking wave, right? Because the signal will be going away from them. So the total is, if it is more than 35 mm, so then you are 100% sure that we are talking about the right ventricular hypertrophy. And there is biphasic P wave. That means, and plus, so all these things, and plus you will be able to auscultate also, right? We'll see that dealing with the auscultation. So you are dealing with the tetralogy of Fallon, because these things, they were present into a kid, right? So here symptoms, the amount of pulmonary blood flow, major role in symptoms. There is decreased exercise tolerance because systemic desaturation. The blood is flowing from right side to left side, right? So carbon dioxide, mixed blood is getting circulated to the entire body. And patient with tetralogy of Fallon, because there will be fluid overload. The amount of fluid which should be exiting from the heart is not exiting, right? So that's why there will be overload, because pulmonary wall is stenosed. Poor weight gain, mixed blood is going, right? Tachypnea, breathing would be shallow and rapid, right? And then there is without cyanosis, because it takes some time. Some children who can, this was what we discussed in detail, frequent squatting, right? When they do squat means when they sit like this, baby pose, right? So over here, the venous blood would be squeezed. When the venous blood is squeezed, so here it will be leading to increased pulmonary blood flow. And when there is increased systemic resistance, because the femoral artery is squeezed, then that back pressure will go all the way to the aorta, to the left ventricle. Now, because the left ventricle will be having more pressure, so it will resist the blood which is coming from the right ventricle. So relatively, there will be less right to left shunt. That means relatively, there will be more pure blood which will be going into the aorta. Thus, the baby would be comfortable, right? So hypoxic spell, hypocyanotic swells, right? And then because of this carbon dioxide, irritability, lethargy, all those things occurs. Typically, this thing occurs around 2 to 4 months of age. And as this thing starts developing, right, if the brain is affected, then there will be seizures, convulsions, can lead to even death also. When there is decrease, when the pulmonary system is affected, then it will be leading to clubbing. Clubbing means when the nail bed is raised. So nails will be looking like this curved nails, right? The nail would be like this curved nail. If you see your own nails from side, you'll find that it is flat, right? But if it is bulged, yes, it is a sign of alarm. This, from nails, right? We'll be taking one lecture on that. From nails, you can diagnose, right? You'll be stunned, 27 diseases just from the nails. You just watch nail and you start speaking, right? And there is a complete, like a logical system, whether male or female. What is the age group, right? Then is a child, right? Okay, child. So in that case, you need to watch these things. If it is a male, then these things. Female, then these things, right? You will watch, compare both the nails. You'll watch upper limb and lower limb, right? Then you'll watch the hair, right? You'll watch the eyes. All these will be, they will be giving you what's called as the DD, differential diagnosis. Within 2 minutes, you'll be coming to that conclusion, right? But it would be a combination of so many things. But yes, 27 things which you can diagnose just from the names. Right? So cyanosis in lips and fingers, because lips, it has got thin skin, right? So that's why you'll be able to see the bluish discoloration. And fingers, because it is a peripheral circulation, so it is the farthest from the heart. Clubbing in fingers and toes, we talked about it. Diagnosis, it is stamped by echocardiography, right? Today echo. So here it is the right ventricular musculature. Yes, we can see that it is thick. As compared to this is the left ventricular musculature, almost the same. In fact, right is more, so that means it is right ventricular hypertrophy. This is right ventricle, this is left ventricle. They both are communicating, so this is the ventricular septal defect. And because we can see that aorta is emerging from here, so it is emerging from left ventricle as well as right ventricle. So that's why this is the overriding of aorta confirmed. So we are dealing with, because it is with EST, we are dealing with the type 2. Right? Treatment, cardiac repair surgery as soon as possible, because very few will be able to see that 35th birthday. Right? And in case if the surgery is not done, there is no chance that they will reach even their adulthood. They die within initial few years. Correction, it is a major surgery. ESD is to be corrected with the help of implanter, right? In which this is what is used to fill up that block, right? That gap. Pulmonary constriction is relaxed. Right, this one. Right ventricular hypertrophy, it resolves by itself, because as soon as the pressure from the pulmonary wall is released, so pressure is released, so that right ventricle once again goes back to its original state. Overriding of aorta, variable, not present in every case, but if it is yes, then it has to be, it is like a major correction. Atrial septal defect. Well, it is like, say, I'll just explain you very quickly and briefly, because you have asked. Right ventricle, left ventricle, aorta is here, so it is this much area, right? It is stitched. This much area is stitched, so that now the blood will be going from here. Right? So as such, it is an important surgery, major surgery, but it is done. It requires some creativity, looking at that particular case. And when there is ASD, for ASD, you know that there is again an implanter, but that implanter in which this middle portion is bit thin, and one area is bigger, and the second area is smaller. So this one will be for the right atrium, and this opposite side, that will be for the left atrium, right? The right. Complication, ventricular arrhythmias, because that's what my intention is, that very soon, after completion of this topic, next time, we'll be starting with the arrhythmias. Right? There are 5 different types of arrhythmias. That is pretty, I won't use the word complicated, but yes, you need a very good focus to understand it, because arrhythmias, I'm not insulting anyone, but people are poor in that. Seriously, I'm telling you. Right? Arrhythmias, auscultation, X-ray chest, ECG, EEG, electroencephalogram. When you take the that electroencephalogram of the brain, these are some of the very gray areas. Right? No medico will say कि नहीं मुझे नहीं आता, but trust me, right? You will find you will see that when the X-rays they are shown, many of the doctors, right? Very smartly they'll just see the report and then they will see the X-ray. Right? It happens. CT scan, MRI. Right? I'll show you that yes, they are not complicated. Right? They are very systematic. So, right, this arrhythmias, there are 5 different types of arrhythmias. Importance, those who are planning for USMLE, right? Just simply tell you one thing. If you are planning for USMLE, the most important will be the physiology. It would be pharmac and it would be pathology. Right? Because physiology, it is taken for granted that you should know. And if you know that thing properly, then you'll be able to excel in pharmac and patho. Right? Because patho is like deviation of the physiology. In pharmacology, there are when we'll be dealing with cardiac arrhythmias, so you'll find that there are 5 groups: type 1, type 2, type 3, type 4, type 5. Type 5 different type of anti-arrhythmic drugs. Right? 5 different groups, and then you have to remember all the names. But within 1 hour, you'll be able to understand everything if you have understood the normal, how these arrhythmias occur. So that's the reason that when we'll be discussing, there were 2-3 emails where it is said that we are in first year and are we supposed to learn it in so much of detail? Yes, my friend, definitely. I never considered that whether you are in first year or you are in second year or you are in final year. Nothing. Socho hi mat. Right? It is like jitna seekh sako seekh. Other thing, I think I don't know. I don't remember. मैंने किसी को देखा भी था. बस मेरा फायदा उठाओ. Demand. If you want that, yes, I want to learn this topic, अरे बोल ना यार. Just tell me, right? So when you say, so I integrate that thing into our talk. You are free to talk on any subject, कुछ भी हो बताओ, talk to me, because that's the way to learn medical, right? It is not like just चलो PowerPoint ठक 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 ठक. No, I am against that. Though many of the teachers they don't like, but I am telling honestly. Because this is the way we learn. This is the way with those chalk and board, right? At that time, there were blackboards. Our teacher, बेचारे white हो जाते, right? वो chalk से लिख के. But they were so good. मतलब they used to write and then हाथ से मिटा रहे ऐसे करके. अच्छा, this is the atrial septal defect, right? That's how they used to teach. I still remember my teacher. He was colonel in army, right? And he used to say, and he used to teach obstetrics. The way he has taught the delivery of the baby, and he used to say that, okay, this whole class is like a uterus, right? And they say this is one fallopian tube and this is another fallopian tube. That's how he used to teach. And then we used to laugh. Then he'll say, "Chup, gali de de, gali de de." Then when you जब book में पढ़ेगा ना तब पता चलेगा how complicated it is. But trust me, was after 2 hours there was like enlightenment. यार अब कुछ भी पूछ लो. And we used to, and when we came to radiology, when we started doing the ultrasound, we said, all those vertex and everything are crystal clear. So this is what I would say, that when you reach to that level, you also teach this thing to your next generations. Because unfortunately, none of my teachers are in this world today. But we still miss them. We still remember them. And we used to go by cycle and we used to come by Luna. Simple. And even if we are in the cycle parking, we used to sit, and if we are discussing, and he'll come and he'll say, Chal Jani, bol. And then he'll ask some question. And then he would say, Ghabrane ka, bindas. So we'll be conducting, and same number 42. So that's what I wish. I randomly say, Chal Anvit, unmute yourself and I ask you a question, and then you have to answer. Not right now, but the day you will say, Haan, chalo, we have learned the topic well, let's do it. But then we'll do it. You will generate so much of faith in yourself. Because see, right now we are just 42. Okay? Even if I randomly bola, Kirti, unmute yourself, chal yaar, bol. Tetralogy of Fallot or pentalogy of Fallot, right? Tell me all 5 conditions. Once you will speak confidently, you will always remember for rest of your life, because you have spoken in front of so many people. It will automatically improve your speaking ability. It will automatically enhance your brain to the next level. Many of you must be wonderful speakers, right? But when it comes to knowledge, when it comes to subject, you should be able to express it in your own language. Because I feel like that one day, many of you will be going on a bigger stage, will be representing India at international level, right? Must be taking some good lectures at many of the universities. So when you are coming on that level, it is very much important. People say that I won't take the name, but जो आपने लिखा कि कई बार मुझे इंग्लिश समझ नहीं आती, अरे यार जरा भी टेंशन मत. But yes, I'm not against him. or any of the Indian language. But you must know the English properly. You should be able to speak properly because mano ya na mano ya, books to sari English mein aane wali. And when you'll go to international, you have to represent yourself in English. So it's a matter of practice, right? It's a matter of practice. Kuch nahi hai English mein, right? We don't have to speak that Shakespearean language, ऐसे that Shashi Tharoor style of things. तो वो ऐसे word के पता ही ना चले कि dictionary ढूंढनी पड़े. So no need. So this is the ventricular arrhythmias. That is a major post-op killer, right? Yes, Iman. Okay, coming on to this transposition of great vessels. There are two great vessels, that is the aorta and the pulmonary trunk. Switching positions, that means they just shift in a way. From right ventricle now comes the aorta, and from left ventricle there comes the pulmonary trunk. Rest of the things, they are as such normal. That's why things which are happy with each other, right? So this atria and ventricle, they are happy, forming a happy couple, right? So there is no problem between atria and ventricle. So that is what is called as the concordance. And there is definite jhagda between ventricle and the artery. Right ventricle is telling, "Arey yaar, who are you? Aorta kaun aa gayi?" Right? Left ventricle is telling, "Arey yaar, pulmonary trunk, who are you?" Right? So that means there is jhagda. They are not happy. That is called as the discordance. So do remember, there is atrioventricular concordance and then there is ventriculo-arterial discordance. Right? I marked this because several times such questions come. They appear. They look scary, but as such they are stupid. Kuch nahi hai. So simple. Hai na? So here it is, right atrium, right ventricle to aorta. That is the discordance. Left ventricle, that is concordance, but left ventricle to pulmonary artery, that is discordance. There are two types, the dextro-TGA and the levo-TGA. Levo-TGA, we keep it aside right now. Dextro-TGA, what we are discussing, what we saw is the dextro-TGA. Three types: complete TGA, transposition of great arteries with intact ventricular septum in most of the cases. Complete TGA with VSD, 30% cases. Complete TGA with VSD and pulmonary stenosis, right? That is 20%. So this is a very grave condition. How the baby would survive if these are two parallel circulation, because oxygenated is moving on oxygenated side and the deoxygenated is moving on deoxygenated side. But these are the lifesavers. Foramen ovale and the ductus arteriosus, they are the lifesavers. They are the lifesaver because the blood is getting mixed. So at least they are getting some oxygen. Here it is, from right ventricle, we did this angiography. Catheter has been placed into the right ventricle, dye is injected and the X-ray is taken. Dye is not going on to the left ventricle. So over here, this is the aorta which is going. So that's why we say this is a complete TGA. But because it is not going on the other side, that is the left ventricle, so that's why we say that this is the complete TGA, transposition of great arteries without or with intact ventricular septum. So this is the type 1. Same patient, but now the dye has been injected into the left ventricle to see whether it is getting spilled into the left ventricle onto the right ventricle. No, it is not coming into the right ventricle, and it is going, as we can see from the shape itself, we can easily make out it is going into the pulmonary trunk. So that's why this is confirmed. This is EGA, complete EGA with intact ventricular septum, no VSD, type 1. Over here, this was another case in which we start our journey from here, right, injecting the dye into the right ventricle. From right ventricle, it is going into the aorta. But we saw that dye is spilling into even the left ventricle. Though this is ventricular septal defect, it's not big, it is small, but yes, definitely dye is going, right? We can see the black cloud, blackness over here, right? Otherwise, it remains very clear. The way it is clear over here, right? Crystal clear, right? This portion, crystal clear. There is no dye. So over here, as it is going, right, this aorta is getting smaller in caliber. So there is hypoplasia, right? Plasia means growth, hypo means less. So aortic arch has not grown. Its growth is restricted. So it is a smaller one. Plus there is narrowing. So that is coarctation. Coarctation means narrowing. Right? it is narrowing, and then the aorta is going. This is the pulmonary trunk, and this in between portion which we marked, that is the patent ductus arteriosus. So these are the major findings into this, right? Given over here. 2D echo, right ventricle is going to aorta and left ventricle is going to SPT, but in between there is no, the entire septum is intact. So that's why we say that this is a type 1 because there is no EST. Hemodynamics, unoxygenated blood or deoxygenated blood. From superior vena cava, inferior vena cava, they'll be going to right atrium to right ventricle to aorta, systemic circulation. And then similarly, the pulmonary veins, they'll be going from left atrium to left ventricle to pulmonary arteries. That is the pulmonary circulation left to right. Right? So thus, they are parallel circulation. In reality, right now, we all are having series circulation. So from systemic, it goes to pulmonary. From pulmonary, it comes back to systemic. So that's how blood keeps on moving, getting oxygenated, getting deoxygenated. So without mixing of unoxygenated and oxygenated blood, patient develops severe cyanosis, hypoxemia, and the metabolic acidosis. And patient dies. Baby dies within 1 week. 1 week is also more, even before that. In fetal life, there was not much of a problem because everything was coming from the mother, right? So foramen ovale and ductus arteriosus, they were lifesaver, but no more. Right now, the things are different. We need to keep that patent ductus arteriosus, that ductus arteriosus patent. We cannot let it close. So that's why we'll keep on giving the injections of prostaglandin. So prostaglandin will keep that thing open because ductus arteriosus is a chemosensitive. So that means in absence of prostaglandins, those receptors would start contracting and the whole thing will get fibrosed. But if the prostaglandin is coming, so that those receptors, they won't work and it will keep it open. So this is to keep ductus arteriosus open. This is the importance of receptors. Right? So X-ray, this is egg on a string of needles. On to the levo-TGA. Levo-TGA, when the God himself, he corrects the whole thing. So this is what is called as a congenitally corrected transposition of great arteries, right? One of the superb thing. What happens? By mistake, I think I erased that. No problem. I'll draw it again, right? So what really happens is, this is the right atrium, this is the left atrium. This chamber, it has to be right ventricle. No, this is left ventricle. This chamber has to be left ventricle. No, now this is right ventricle. This was the mitral valve. Sorry, this time mitral valve is here. And this one would be the tricuspid valve. So that means that the great arteries, they switch positions. Ventricles, they switch position with valves. Right? So they switch position. This is what is called as the levo-TGA. So what really happens? Now this is left ventricle. From left ventricle, what was, because of this, that's why it is called as transposition of great arteries. It means it will be the pulmonary trunk which is going on. Pulmonary trunk will go to lungs. From lungs, blood will go to left atrium, right? Because that is the pulmonary veins, right? That oxygenated blood, this is oxygenated blood, will go all the way via tricuspid to right ventricle to, right from right ventricle, it is the aorta, right? It is the aorta. From aorta, it goes to body, right? Body uses that oxygen and then everything comes, returns into the right atrium, right? Now there is carbon dioxide. And then things continue. Wonderful, right? This thing would work fine without much of the trouble. This is, the patient is acyanotic, right? Like a normal heart, and it will work fine. Trouble. Yeah, why it occurs? But in adult, means baby passes its childhood comfortably, but as the patient grows, right, there is valve failure. Because now the body will be demanding more oxygen, more blood. So when the blood will be thrusting through that mitral valve, that tricuspid valve. Tricuspid valve, the bichara was made for that weak flow, pulmonary. right? Pulmonary pressure, which is so less. While over here, though, it is big pressure, pulmonary valve fails. So that's why the commonest, this is also one of the questions that is in Levo TGA, which valve would be replaced in most of the cases, and then you will be having all the four options: mitral valve, tricuspid valve, aortic valve, and pulmonary valve. So now you know that, right? Which valve, and with the reason. Risk factors if expecting mother, right? She is protein, PEM, protein, energy, malnutrition. Right? It is protein, energy, malnutrition. So if the protein is less, protein is just simply consider it like it is the building block, right? Carbohydrates, they are like petrol, right? Fats, they are like oils for the lubrication, right? Your joints and everything. But the protein is for the repair works. Whenever you do exercise, right, heavy exercise, so your muscles will break. That is called as a micro injury. You take protein. You know, many times, many of you are going into the gym from the emails. I could make it out. Right? No, it is not. This question was asked. No, it is not at all. It is a very big misconception that exercise key immediately after that you have to drink protein. Or a boss protein that will go into your stomach. From stomach, it will go further. Then it will be coming into the portal system. Portal to it will go to liver. Liver will metabolize it, Krebs cycle and everything, and then it will generate, and then it will be absorbed by the muscles. This thing takes 4 to 6 hours. So there is no point that exercise key and after that you are drinking protein, you feel ke, no, it is simply because the amount of sugar which is present into it. So that sugar is giving you the kick, because the sugar is 10 times more addictive than cocaine. Sugar is that bad. So it gives that transient euphoria, but after that it is not at all good. So that's why, yes, you ask that what type of proteins. I would say go for those proteins which are having the least sugar, right? And second, if you can afford it, you should go for, whey proteins, they are good, but isolate whey, they are still better. Isolate whey. They are slightly costly, but isolate whey because that they are not having any carb, right? Any carb. So you are not pumping any of the carbohydrate. Remember, by eating good fats and good protein, you will never become mota. You will never become obese. You will become obese. You will not be able to lose weight if you are eating carbohydrates, carbs. Chalo, next time we'll take exercise physiology. Right? This would be the topic of next time. Exercise physiology. We'll take this. It's an amazing topic. So many concepts would be clarified, and because it is touching your life, that's why. Then diabetes, alcoholic, if the mother is 40 plus age, and if she has suffered from rubella, so these viruses, they are also very much known to cause this genetic disruption resulting into this TG. Right? So now we are coming to the third topic, which is what is called as the truncus arteriosus. Simple, truncus arteriosus is that tube from which a septa develops, and then there would be development of pulmonary trunk and the aorta. Right? So basically, initial tube, which is called as the truncus arteriosus. So in fetal life, it divides into pulmonary artery and the aorta. Right? This is pulmonary trunk or pulmonary artery, right? For our convenience. So if no division, remember, if there is no septa developed, we learnt embryology, right? And then at that point I said that if you learn embryology properly, so then all these variations, it is just the variation in the development. So see, if the septa is not developing, that means it will be a single artery. Single artery. Septa is not developed, so it will not be developing into pulmonary trunk or aorta. Mixed blood in body and lungs. The rest of this common tube is emerging from the heart, and then it is one branch is going to the body. From that only the branches will come and it will go into the lungs. So that's it, right? So it is a single large artery which is present and it is coming from both. Okay. So here, can we say it something like this? Right. If you divide it like this, right atrium, left atrium, right ventricle, left ventricle, and this is a common. This is where the mixed blood will be coming, right? From here, because the rest of the thing, rest of the cell from lungs, one branch will go here, it will come here. From here only, it will go to body, right? And from body, the blood is returning here. So everyone is getting the mixed blood. So that's the reason. Many times, it is also said that right ventricle and left ventricle, in such case, they behave like a common chamber. Right? So heart is like this, but then the septum which should have developed between right ventricle and left ventricle, that is there, but aage jaake to it is same trunk na. So that's why the right ventricle and the left ventricle, now over here, this is like a common chamber, and it is in this chamber mixed blood is going on. So complications. Yeah, you can say, but say in fish heart, yeah, actually it is like a fish heart. So complications, cardiomegaly, right? Pulmonary hypertension, because say in aorta is able to withstand that powerful pressure, which are a pulmonary system, so they are weak system. They are also the left ventricle is contracting and pushing the blood. So that leads to pulmonary hypertension. Pulmonary hypertension will lead to what? Will lead to lung damage, because lungs, they are very delicate. So it can lead to lung damage. Lungs are damaged, so there will be respiratory problem, correct? When we have so much complications into our patient, so then this is the SA node to AV node. These are our pacemakers, but it is this area only which is having problems, right? So there will be formation of many types of arrhythmias. We'll discuss when we'll be discussing arrhythmia in more detail. Valve regurgitation, because when there is aorta, right, and the pulmonary trunk, everything is mixed, one common trip. So then where are the valves, right? So there is practically nothing like valve. So blood will be going back also, back and forth. Valve regurgitation. Thus, cyanosis, baby will turn blue, right? Few days after birth. More blood to lungs, less to body, because high to low pressure system. The body is always, the things are like that. Here is the left ventricle, here is the right ventricle, right? And out of that, over here, the common is going. But when in the body, when the body is over here, the body offers so much of resistance, you know, because there are so many big arteries, then there are muscles, right? There is so much of resistance. Over here, तो there is must acute lung, कोई resistance नहीं. So blood will be, चलो ना ये, this is easy, right? Blood will be pushed into the lungs, because it will always try to find out which path is easy. This is the path which is having heavy resistance. When in normal life, it happens like that left ventricle, that's why it is so ताकतवर, right? It will push the blood all the way to jaw, right? And it will reach till the toes of your last cell of the toes of your feet. But now there is an easy way. So more blood will be going, that is what will lead to pulmonary hypertension. And when the blood is getting pushed, this poor body is not getting. So that's why it will start turning blue. Right? And then there will be fluid overload, heart failure, because it is going into incorrect direction. So the amount of blood which should have exited into the body, because body can take more blood. These lungs, so they will take how much blood? Minimal, right? So then there will be accumulation of more fluid and the heart fails. And this is associated with 22q, 11.2 deletion syndrome, George syndrome. You know that treatment, surgical well, right? No option. It has to be, and it is like a major surgery. On to our fourth condition. Now you'll find these conditions very easy, right? You'll understand within minutes. Hypo means small, plastic, left heart syndrome. left heart is small. Congenital underdevelopment of left heart. Right? Left heart. So when the left heart is small, so primary congenital heart defect may reduce flow through left ventricle and the left outflow tract, obviously. When we draw the heart like this, this is the left atrium, which are so much small. Won't be able to handle. This left ventricle is small. So even if the aorta is normal, there would be less blood which will be pushed into the aorta. Right? So it affects other heart malformation because this is never standalone. There are even mitral valve problems and arrhythmias, all those things. Because when in the formation, when there is problem of formation into the left atrium and the left ventricle, so there will be formation of the ventricular, this SN node, AV node. So there will be arrhythmias. So many things occur. Underdeveloped left ventricle and aorta. Aortic mitral valve, they are affected, they are narrow, or sometimes they are absent. There is atresia, right? Or there is just a small, very small hole through which the blood is trickling and which is not sufficient. And many times patient don't even survive if untreated left-sided heart failure. No doubt about it, because right heart is working and it is dumping that blood, but left heart is incapable of handling so much of blood, fails. And that thing is what is called as the cardiogenic shock. The shock, right? Shock, when we say electric shock, that is shock. But then there are various types of shocks. Right? Say, for example, cardiogenic shock. When the body suffers so much of panic, so much of problem, and death occurs. There can be anaphylactic shock. It is called as anaphylactic shock, which is because of the allergic reaction. The immune system comes into picture, right? So person is unable to speak because larynx, they are dilated, right? Person whole face is swollen, becomes red, right? So all those anaphylactic, heart races. So all these are various types of shock, which itself is a giant topic, right? So burns shock can occur because of burns. Right? Cardiogenic shock, anaphylactic shock, so many types. Right? So this will also be one of the very fine topic of medicine. Right? Medicine. So your responsibility over there would be two. One, identify the type of shock. And second, the whole treatment is divided into two parts. Anaphylactic shock, if it occurs, you've got 3 to 4 minutes because there is so much of laryngeal edema. Person is unable to breathe, right? So you have to do some things in emergency so that when it is a matter of saving the life. And then second is the standard treatment. So that's how the approach will be. Same way, the myocardial infarction, about how to treat myocardial infarction. One of the email which was like how to treat it. Well, we'll discuss that. Right? But we'll discuss that thing in pharmac, because once you know that what would really happen why you call that digitalis is cardiotoxic, cardiac tonic, right? So there will be several examples. Many times I'll be telling that never strike a tired horse. The ghoda thak gaya hai, and still if you keep on usko chabuk maro to he'll run, but then he'll die. Right? So never strike a tired horse. So these are some basic principles about how will you decide which drug to give. Right? And it is a matter of you see ECG and you'll say, okay, go for these drugs. Right? And you are 100% right. It's simple logic. Right? So we'll study that. Okay. So if untreated left-sided heart failure, ASD, atrial septal defect, and the patent ductus arteriosus required for postnatal survival. Got it? Right? This is the. So if there is atrial septal defect, yes, the blood will be moving over here and here, right? So this left side won't fail because it has got a path from where it can go. And over here, there'll be pulmonary trunk, right? Over here, there'll be aorta. This would be the PDA, patent ductus arteriosus. So here also, it will get a path to shift the blood, right? The blood would go. if required, when the pressure would rise, right, so it would prevent the left-sided failure. But yes, body will be devoid of this blood, so there is always a compromise, but at least patient would survive. Right? So that is what is needed for postnatal survival. So this gives you some window within which you have to operate. Symptoms: respiratory distress, poor feeding, failure to thrive. Thrive means growth, right? Growth. Failure to thrive. And the left-sided heart failure, we talked about it. Diagnostic imaging: one, prenatal ultrasound. Very important. Prenatal ultrasound. When the mother is expecting, at that point only, it is very vital to do the ultrasound and figure out that what's the trouble. Because immediately after birth, one has to go for that surgery. X-ray chest will show the cardiomegaly. ECG, right ventricular hypertrophy after birth. Right? Surgery, surgical repair. Right? No other option but to do that. All right. So over here also, right? Here also, you need to keep that PD open, patent ductus arteriosus, right? Because that is needed. So here also, in treatment, if not much, at least prostaglandins, they are needed. Correct? Right? So important. On to the final topic. Right? After that, there are the fifth topic, atriovenous malformation, that is very small. This is important. This is not complicated, but just I'll give you some brief about the anatomy. If you have learned, if you have already done the thorax, right? If you have learned a bit about it, you'll find it easy. Doesn't matter. Total anomalous pulmonary venous return. This is what is called as the TAPVR, right? Abbreviated form, total anomalous pulmonary venous return. Now, this is the anomalous. Anomalous means incorrect or the wrong connection of the pulmonary veins and the heart, right? And this occurs during first 8 weeks of fetal development. Makes sense, because we understood that it is in the initial 8 weeks when the heart was getting formed. If there is any error during that form, this is what really happens. Now, there are two variants. One, what is called as the supracardiac variant, and second, which is called as the cardiac variant. Supracardiac means above the heart. Supra, above, right? And this is most common. So, in order to understand this, let's draw this. Once again, our own standard figure. What happens? This one is superior vena cava. Superior vena cava, how it is formed? It is right brachiocephalic and the left brachiocephalic vein they meet. So this is the right brachiocephalic and the left brachiocephalic. Right brachiocephalic vein, and this is the left brachiocephalic vein, right? Vein. So they meet and that forms the superior vena cava. Inferior vena cava, you know that if this is the diaphragm, this is the heart, and it just enters straight away. It enters into the left, into the right atrium. From top goes inside the superior vena cava. So we'll focus on superior vena cava. Sorry. So for superior vena cava, for the supracardiac variant, pulmonary veins, they open into brachiocephalic vein or the superior vena cava. Pulmonary veins, so they open into left atrium. So these pulmonary veins, right, which were supposed to open here, they are going here. They are opening into brachiocephalic vein, or they are opening into superior vena cava. Right? Here the heart is normal. There is no problem with the heart. But the veins, pulmonary veins, these are pulmonary veins. Now, pulmonary veins, remember, they are carrying oxygen. It is from lungs. It should have gone into left atrium, then to mitral, then to left ventricle to aorta. No. Pulmonary veins, they are opening into this system which is already having deoxygenated blood. So that oxygenated blood, now it will enter into right atrium to right ventricle. And then from right ventricle, pulmonary trunk. And from pulmonary trunk, it will go to lungs. And from lungs, pulmonary veins. That means which are a left atrium and the left ventricle to अनाथ हो गए, right? There is no one, right? बिचारा aorta, right? Aorta will say कि बस no one. So then how to survive? Coming back to same thing. Prenatal life, not much of the problem. Why? Because there is no lung. There are no lungs. Mother is supplying, right? There is foramen ovale. So whether these pulmonary veins are there or not, who cares? Right? Because in any case, those lungs, they were shut. You know? So no issues. And then there was PDA, ductus arteriosus. So that ductus arteriosus was handling. Same thing occurs in this also. Baby survives simply because of these two, foramen ovale and the ductus arteriosus. Foramen ovale, right? We'll call that thing prenatal foramen ovale. After birth, we'll call that thing as AST, right? So basically, it is the same thing, but it should have closed now after birth. If it is remaining open, then we call it AST. So that is what is called as the supracardiac variant. Now, next is easy. When we say cardiac variant, simply, right, you are smart enough. Cardiac variant means now it is entering straight away into the heart, right? So where it is pulmonary veins, they open into coronary sinus or the right atrium, directly right atrium, which are all babal khatam, straight away into the right atrium. Finish. So in right atrium, superior vena cava is also coming, pulmonary vein is also coming, and a khichdi, that mixed blood is going further, right? So whether this is more common, right, supracardiac. There is another variation. And this variation, which is extremely rare, right? I mean, I haven't seen a case of this, but theoretically, it is what is called as the infradiaphragmatic variant. Infradiaphragmatic variant. So where pulmonary veins, they open into portal or the hepatic veins. Now, let's use this. You need to understand this. Here is the liver, right? On our right side, you got the liver. On the left side, when you do it like this, right? So that is where the spleen is there. So this one is spleen. We are now into abdomen, right? So this one is the liver. I'll write the liver here because we'll need that space. So there is one vein which is quite tortuous. So we'll call that thing as the splenic vein. Makes sense? Right? Splenic vein, because it is coming from the spleen. Now, in the abdomen, right? In the abdomen, so here is esophagus, that's the stomach, that's the duodenum, right? Duodenum part 1, part 2, part 3, part 4. And then there are small intestines. So this is duodenum, jejunum, and then finally it comes, and this is the ileum. There is ileocecal wall. This is the appendix, right? This is the appendix, and then there is colon, correct? Colon, and there is the rectum and the anal canal. This entire thing is divided into 3 parts. Right? It is divided into 3 parts. The first part ends at this point. Second part, it goes all the way and it ends at this point. Right? So then, thus we call it foregut, midgut, and hindgut. When we'll be learning the digestive system, we'll be learning it in more detail that how those twists and turns occur so that it means today. But foregut, midgut, and hindgut, they are supplied by one individual artery, one individual vein, and one individual, even there is a separate nerve supply. So it's such a wonderful system. Now, why I explain this? Because there are two major veins which will be coming, and they are called as the mesenteric vein. They are called as the mesenteric, right? Mesenteric vein. So they will be coming deep from the abdomen. So this first one is called as the inferior mesenteric vein. So from this inferior mesenteric vein, right, whatever the food which you have eaten, right, digested, right, and then broken, and then it is taken into these veins, and then it will say, chalo, let's go to liver, right? Then so this splenic vein, it joins inferior mesenteric vein. Splenic vein continues, and there comes, right, the blood flow is in this direction. Right? This is another vein which is superior mesenteric vein. Superior mesenteric vein. So it joins splenic vein. From top comes the gastric veins, right? Gastric, stomach, gastric veins. Right? Thus, the vein which is formed, and that is what is called as the portal vein. Portal vein. If anything happens to this, multiple complications. So this portal vein, it enters into the liver, and in liver it divides into right and left branches. There would be another vein, but let's not draw it. It is called as the cystic vein. That cystic vein, it is from the gallbladder, right? It's from the gallbladder. Anyway, so this is what really happens. This thing is called as the portal circulation. So now the liver, right? Whatever, when they say daru peene se liver kharab hota hai, the reason is that daru will be coming over here, right? Liver will be analyzing, metabolizing it, and then finally it will give the output. That thing will go into the form of what's called as the hepatic vein. Hepatic vein. This hepatic vein will be landing into inferior vena cava. From inferior vena cava, it will go to right atrium, right? The right atrium too, it will go to right ventricle, and thus it is into the circulation. Now it will start reaching from right ventricle to lungs, then from left atrium. So that nutrition is there, so it will be giving to the entire body. But this is the path. As we said, that liver is like a cashier, right? It's like a mazdoor. He will work. He will say, whatever the nutrition whatever the work I do, but I need oxygen. So he'll say, okay, you need oxygen. So here comes one artery. This is what is called as the hepatic artery. Function of hepatic artery is only one: supply nutrition, give pay to the liver so that liver keeps on working, right? So this is what is called as the hepatic artery. And then there is function of liver is to produce bile. So there is one more duct, right? And that duct is the bile duct. Bile duct. So hepatic artery, portal vein, and the bile duct collectively, right? These three are called as the portal triad. Portal triad. So that is combination of all of them, right? So this is 1, this is 2, this is 3. Now we come back to this. Why we learned this? Pulmonary veins, they open in portal or the hepatic vein. Now tell me, if they, bichara, the food which was coming from, or the food which was to be died, which was broken and then it was to be metabolized into the liver, the pulmonary veins are entering here. So this thing, those pulmonary veins, they'll be carrying oxygen. It will go into the hepatic system. It will go into the liver. Liver will use that bindas, right? Muft ka oxygen, right? He will use it, and whatever bacha kucha, right, he'll give it to hepatic veins, to IVC, to right atrium, to right ventricle, and then once again from right ventricle it will go to lungs. It will go to lungs. From lungs it will go to pulmonary vein, and those pulmonary veins, they are stupidly opening into this portal system. So again, bichara apna left atrium and the left ventricle, right? They don't have any blood. Correct? So the idea is just to emphasize this, that these systems, they are defined in such a way, they because of this error, that left atrium and left ventricle, they are not getting anything. There is no systemic circulation. Oxygenated blood travels through portal veins, pulmonary veins to right atrium, right vein. Right, blood does not leave pulmonary circulation. It is remaining, so there is no systemic circulation. Incompatible, right? Baby won't survive at all. This is the reason prenatal ultrasound, it is important that yes, you diagnose it before, right? Because till the baby is not born, no problem. Unless foramen ovale and the pes ductus arteriosus, they are present. Oxygenated and deoxygenated blood mix, establish connection between pulmonary and systemic circulation, and life goes. Right? Anomalous connection often accompanied with pulmonary vein obstruction or the pulmonary venous hypertension. In that case, severe cyanosis. Means itna kharab tha. On top of it, this is pulmonary trunk, correct? Pulmonary trunk, right ventricle. From right ventricle, it is the pulmonary trunk which is going. And the valve which is over here, now that is stenosed. If that is stenosed, then unnecessarily the whole system is now getting higher pressure. Not only that, even it will generate higher pressure over here into the portal system also, because it will back pressure. Right? So symptoms, severity of symptoms depend upon presence or the degree of obstruction. Cyanosis, tachypnea, rapid breathing, tachycardia, fast heart rate, dyspnea, difficulty in breathing, failure to thrive, that is growth, and recurrent respiratory infections, because pure blood is not flowing, so everything is getting mixed. In case of infradiabetic variant, liver enlargement, right? This is one of the questions. But once you know this, right, it is, isn't it very simple, very logical, you know? Because that pulmonary vein was opening into this, right? So much of blood, so that blood will be gushing into the liver. So this liver is bound to enlarge, because there is so much of blood is getting pushed into it. So it will enlarge. That is what is called as the hepatomegaly, right? Hepatomegaly. So that is the liver enlargement. So this is the thing in case, and it will develop only in case of infradiaphragmatic variant. Now see, you are smart enough, right? The question will be formed in this way. That in TAPVR, total anomalous pulmonary venous return, in which condition there will be liver enlargement. Now what they'll be super smart. They'll be giving you the option supracardiac variant, cardiac variant, infradiaphragmatic variant, infracardiac variant, which is nothing like that. Right? There is nothing like infracardiac. Yet it is infradiaphragmatic because it is going even below the diaphragm. Am I right? Right? The liver and everything, if this is the diaphragm, the liver is over here. It is below the diaphragm, and entire anomaly is occurring at this point. So it is infradiaphragmatic. Infracardiac will be this area. So there is nothing like infracardiac. Right? So thus 4 variations are given. And then when someone tells, "It is such a difficult," what difficult? Right now, you know it so crisply. Because it is going into portal or hepatic, so it is only this possibility, infradiaphragmatic variant. Chest X-ray, it is called as the snowman sign. This is spot diagnosis. Figure of 8. You see it and you remember it. Dilated superior vena cava, pulmonary vein, brachiocephalic artery forms head, and dilated right atrium forms snowman's body. Right? Jara bhi complicated. Just see this, and in fact, you know all these things. देखते ही नहीं लगता, right? This is like right? That snowman, right? Snowman sort of. So this is what is called as the snowman sign. Figure of 8, right? This is another name. Figure of 8. Figure of 8. So here, two things there. This, the head portion, right? This is the head. This one, this head portion. That head portion is by over here. Then normally the superior vena cava is so sharif, just this one. But now because of this, right, pulmonary veins are opening into it, so this will be dilated. So this is the superior vena cava, right? Pulmonary veins, they are dilated. So thus they will be forming that bulge on the top. And then from superior vena cava and pulmonary vein, the blood will be gushing into right atrium. So see this, right? You know that normally the right atrium to bichara is so seedha, but now it is dilated. So this is right atrium, is over here. So thus this is a normal shape. So head is formed by superior vena cava and the pulmonary trunk, and the body is formed by the right atrium. So that globular form. So this is what is called as the snowman sign. So in echocardio, very easy. Right ventricle and the pulmonary artery volume loading, right? So that might show left atrium with no connecting veins in echocardiogram, right? In echocardiogram, when you'll see, so you'll find that there is no connecting vein to the left atrium on ultrasound. And on ECG, right ventricular hypertrophy. So that comes to right axis deviation, right? Minus plus, lead 1 and AF. And you know that further, correct? This takes us to this vascular malformation. Vascular means vessels, right? Vessels. When the vessels, they are getting long. 3 types. At this point, even if you don't remember any of these names, no worries, no worries. Kaposi sarcoma, it comes at so many other places. So just keep in mind, Kaposi sarcoma, hemangioma, and the angiosarcoma. In patho, we'll be discussing all of them. This is just for the completion of topic so that you know that what it is. Sarcoma means it is malignancy. Right? In medicine, just remember these 5 points, right? Though we'll be discussing it in medicine. But for the etiology, right, it is called as the etiology. Etiology means any of the disease, why it forms. So there can be congenital things, congenital, traumatic, inflammatory, neoplastic, and miscellaneous. Our brain can remember anything if it has got a pattern. So whenever we'll be studying medicine, we'll always be taking this order: congenital, traumatic, inflammatory, neoplastic, miscellaneous. Traumatic, acquired, means done deliberately or accidental. Right? So it is like if someone is having a broken bone, so then broken bone, right? Let's say broken ribs. So then that rib was why it's broken. On X-ray you see it. But then you see that there are metallic sutures. Metallic sutures, oh, the patient has gone open thoracic surgery, cardiothoracic surgery, right? That's why those metallic stitches were taken. So that's why with the drill, the ribs were cut. Or it was an accident, right? So that depends on something which is right from the birth, or it is because of injury, or there is any inflammation, or there is neoplasm. Neoplasm means cancer. Cancer, they are of 2 types: malignant, right? Malignant and the benign. The malignant is dangerous, right? Because it can really spread, right? Benign, ek jagah pe baitha rahega. Typical thing on ultrasound, you'll find that it has got a definite capsule. definite capsule. So it will be restricted into that much area only, right? Benign. So that is whenever the word oma comes, oma, so that means it is benign. And whenever the word coma comes, right? So this sarcoma is malignant. Hemangioma, that means it is benign tumor. So thus they can occur. See, angiosarcoma, malignant, right? So here this is Kaposi's sarcoma, in which there is malignant tumor of endothelial cells. Endothelial means if this is the blood vessel, so then inner lining of the cells, they are called as the endothelial cells, right? These are endothelial cells. So these endothelial cells, when there is cancer of that, so that is called as the Kaposi's sarcoma, seen in patients with suppressed immune system. And then there will be even skin lesion. There will be some other reasons, the other things also. Hemangioma, yes, we know that same cells, when there is benign tumor, so we call it hemangioma. When it is malignant, that means it can really spread here and there. So then that is called as the Kaposi's sarcoma. And then angiosarcoma, these are the malignant cancer to liver blood vessels. So vinyl chloride, arsenic, these are some poisons, or the occupational hazard, especially this vinyl chloride, etc. Those who are into the company where the paints are made, right? Paints. So that is where such workers, they can get this, and that is what is called as the occupation hazard. Finally, this is atriovenous malformation. Very simple. This is the artery. That artery divides. And finally, it becomes those capillaries. Through capillaries, right, the oxygen carbon dioxide exchange occurs. Then once again, they start unite, and then they form the vein. Correct? So this is what is called as the capillary bed. This is called as the capillary bed. Sometimes this artery and vein, right? So oxygen carbon dioxide exchange, this is the single connection between artery and vein. So this is a shortcut, Mara. This thing is called as the arteriovenous fistula. This is bad, right? Because this was the area where oxygen carbon dioxide exchange was occurring. This blood is bypassing the vein, right? So there is absent capillary bed. Most often this happens in brain, spinal cord, and lungs. These are the areas where it is vital. It is vital because in brain, the brain tissue is getting the blood from this part, right? Spinal cord is getting the blood and the oxygen to survive. These are the neural tissues. Once dead, gone forever. Lungs, because if the lungs will give the oxygen, then it will be taken to the entire body, right? So it's the supplier. So if they rupture, they cause neurological symptoms because they'll be affecting the brain and spinal cord, and later it can lead to heart failure because there will be formation of clots and so many other complications. So this was about the congenital heart disease. So thank you so much for your patience. Thanks a lot. And it's always a pleasure to talk to you. I'll send this file into our shell folder right now. Thank you so much. Take care and see you soon.